Shall we start, do you think? Okay.
Oh, yes.
So I'll introduce you first briefly. Siobhan Brennan is a wonderful person to bring in today to talk to you all about Pure Tone Audiometry. I'm really thrilled that she could join us. She's a clinical lecturer in audiology at the University of Manchester. She is a lead clinical scientist in audiology at Sheffield Teaching Hospitals. She's the chair of the British Society of Audiology. She's also a specialist in learning disability and autism, with, I think, a very broad skill set and some real insights into the needs of people. Is it particularly younger people with learning disability and autism?
I tend to work with the full age range, well, and I'm based in an adult trust, but I do sometimes work with children as well.
Thank you, Siobhan. And I think it's important to note that within your work associated with the British Society of Audiology, you've been working on an update to the recommendations on Pure Tone Audiometry, and so really you're hearing from the expert in the British context, and I'm very happy that you could join us. And I will be encouraging all of our CDT, Centre for Doctoral Training students, and also our LAURA students to listen either in person or online or to the recordings. I will pass over to you, Siobhan. Thank you.
Thank you very, very much, Simone, for letting me talk about this particular topic, because we're really, really excited about the potential changes. And thank you very much for everyone who has an interest in this particular topic. So you can see my slide, isn't that right? Yeah. Okay. So just to provide a little bit of information around the British Society of Audiology. Audiology actually has more than one large national body, of which we are one, but our specialism is producing guidance. So if you are to carry out a particular form of test, for the most part, you would go to the British Society of Audiology for your guidance and your protocols. And we have 9 special interest groups of various different areas of people who will both clinically and research, from a research background, be specialising in these particular topics so that they can write this guidance and look at the evidence base and pull all of that together. We currently have around 50 documents. If you want to take a look on the website, they are freely available to anyone in the world to download and use as they want. So if you're interested in any of those, but what I wanted to talk today about was the audiometry guidance. This is our possibly our longest standing document, and it is the fundamental test that we do. So if you go for a hearing assessment, with the exception perhaps of otoscopy, where somebody's looking in your ears, I would say that Pure Tone Audiometry is the most common test that is used. It is our sort of fundamental test. It's the equivalent of an optometrist asking you to read out the letters. And what it's actually doing is looking at the quietest sound that people can hear across a range of different frequencies. But are we actually doing it right? Because it's one of those tests which is embedded in so many research projects within audiology, but also within most clinical settings, it is one of those tests where it has reached a point where it's not really been challenged in recent years, and it's just so well established and people don't have particular problems with it that it's not really challenged. And of course, one of the things that we have to do as an organisation is look at our guidance regularly and say, well, actually, has something else come out that makes us go, we could do this better? And where is the evidence behind an awful lot of the aspects of Pure Tone Audiometry protocol that we use? So what is the aim of audiometry? We want to find out the quietest sounds that people can hear. We want information about each ear individually. Ideally, that's not always possible, but we want to find out about how each ear is performing in isolation. And we want to look at a range of different frequencies that people can hear. And the most standard way of doing this, but obviously there's some variation, is that we ask people, when you hear the sound, press the button. In terms of the background, audiometry has barely changed over the last 150 years. So these are some genuine instructions for audiometry from 1879. And they are remarkably similar to our instructions now. So the person whose hearing is being tested should sit in an easy position. Fine. The person needs to be relaxed. Should not see the act of the observer in moving the microphone key. So should not see what the tester's doing. So not be influenced by their visual input. For good observation, the room in which the experiment is made should be large. I'm not sure why that's necessary. We don't necessarily have to have a room of a certain size to do audiometry. All external causes of sound should be silenced. Fair enough, we want to do it in a quiet space. The sitter should close the ear that is not applied to the telephone, because of course the audiometers at this point were very similar to how the telephone would look. While he is listening for minute sounds, and should give his full and calm attention to the proceedings. I love this last line. Any excitement is likely to lead to error when refined measurements are required. I love this sentence. And I cannot remember the last time in a clinical setting where somebody being overexcited was the reason for the test not being accurate. However, one of the very, very important points that somebody has made was one of the weaknesses of these tests was a lack of accurate quantitative measures. So there was quite a lot of debate as to how accurate these actual thresholds were. But at the time, remember, amplification, so hearing aid technology and so on, was so poor and so vague, I would say, that actually such quantitative sophistication became irrelevant. That is no longer the case. We do now have a very, very strong desire to be much more accurate, much more precise in terms of our diagnostics, because our rehabilitation opportunities are much, much better. Okay, so what is it that we do? So the current method is actually based on a technique that Carhart Jurger, in terms of the presentations of the sound, what order you do that in, what we're asking people to do, is based on a test that was established in 1959. So the tone is presented at an audible level. So basically you're telling that person what it is that they're listening for, and then reduce the level in 10 dB steps until there are no more responses. Then you increase by 5 dB steps until they do respond. And then you continue to go down in 10 whenever there's a response, and then up in 5 until there is a response again. And where threshold is defined as the lowest level at which the subject responds at least 50% of the time. So where did that come from? Why did we define threshold as 50% of the time? So it would be lovely if there was a specific intensity above which the sound was always audible and below which it was not. And there was a single figure at which we could say, this is the quietest sound that people can hear. But because of the anatomical makeup of the ear and how the ear functions, that is not the case. And what is actually the case is above a certain level, yes, people will be able to respond. And then below a different level, people will not respond. But then in between, there are levels at which you might respond, and your probability of responding increases with increasing intensity. So we have to define where along that curve we are going to say threshold is. So is threshold the point at which you always respond, or the point at which just above you never respond? Well, we've decided that it's the lowest level at which responses occur in at least half of the series of ascending trials. So as the sound comes up again, so from a point of not being able to hear it to being able to hear it, responding 50% of the time at that point. However, because of this range of values, and because we know that actually it varies from test to test, if you select the point at which people respond 50% of the time, that will not always give you exactly the same level. However, provided that variation is less than our step size, that's okay. Also, the width of that particular function between being not audible and audible varies with both frequency of presentation and also whether or not you have a hearing impairment. If you have a hearing impairment, there is a greater degree of variability. Sorry, did somebody have a question? I just heard. I didn't want to. Okay, no mind. I'll carry on. Okay, so if you've got a hearing impairment, that curve is broader. There is more variation between response to response. Other things that can affect the shape of that particular curve are age and cognitive factors as well. If you happen to have pathology affecting your cognition, that can change the effect of that level as well. So when we're asking people to respond, you would think that, well, it doesn't matter how you respond. So long as you're telling me that you can hear the sound, I don't care what you do in response to the sounds. But in fact, what we've actually found is that what we're actually asking people to do will influence the accuracy of their threshold and the level at which people tend to respond. The larger the action that we're asking people to do, the more likely they are to engage, and the quieter sound to which they will respond, and the more reliable their test, the more repeatable their response. So, for instance, in some populations, instead of asking somebody to press a button, we will ask them to put a peg in a basket. And we find that by asking somebody this larger movement with their hand, we get better responses to audiometry. The reasons for that are not clear yet, but we want to know. So, but our usual test is button pressing, and that's very convenient because you can see on the screen when somebody has heard it. Some people, and we do tend to see this in older groups. We do tend to see this in our clinic that we have specifically for adults with dementia. We see this a lot, is instead of pressing the button, people will raise their hand. Now, hand raising is fine so long as you can clearly see the hand raising, but very often during the test, it'll start as a hand raise, and then towards the end of the test, somebody may just like raise their index finger or something like that, which can be more difficult for the tester. Sometimes people will mimic the sound rather than respond. And a lot of people, again, we tend to see this in our older population, will describe the sound. Instead of pressing the button, they will tell us whether they feel the sound is loud and soft, giving us that extra information. Again, that causes a little bit of variation. So once you've presented the sound, how long does it take for people to respond? Well, reaction time is typically about half a second. And it's shorter. People are faster when the sound is louder, but it is influenced by cognition and other factors. So, for instance, in the clinic that I work with in individuals with learning disabilities, I would expect people very often to take that a little bit longer to respond. And that doesn't matter so long as it is within the time period that we would expect. However, the impact of that interpretation is obviously susceptible to error. So if somebody is taking a little bit longer to press that button, am I sure that that's in response to sound, or is that just a random button press, which has nothing to do with the sound, and I have misinterpreted it as the tester? So we do have tester bias. This is a big problem. You do have this interpretation of the tester watching somebody respond and thinking, is that a genuine response, or have they got bored and they're just pressing the button randomly? It is more pronounced for bone conduction testing, but I'll talk about bone conduction testing in a minute. And the more experienced you are, the worse you are at this in terms of testers, because they will form an opinion before the test has even started as to what that person's hearing levels are likely to be at. And therefore, this will influence their interpretation of somebody's responses. It shouldn't, but it does. So whenever we give an instruction, we're basically saying whatever the sound, and no matter how faint the sound, press the button as soon as you think you hear it and release it as soon as it stops. There are a lot of people who will only respond to supra-threshold levels. So at the very quietest levels that they can hear, they will not necessarily respond. I have had people whose audiograms don't really make any sense in terms of the levels at which they're responding doesn't make any sense in terms of the ease with which we were having a conversation immediately prior to the test. And I'm thinking that's not quite right. And I'll say, are you responding to the quietest sound that you can hear? And I will present a very quiet sound and they will say, well, yes, I can hear it, but sure, those sounds are no use to anyone. and they will actually come to their own conclusion as to what it is that we need. So they will genuinely be waiting until the sound is loud enough for them to feel comfortable. So they're actually going for comfort levels rather than threshold levels. And we do have to reiterate what we're looking for is threshold. You may think, well, what does this matter? If they want to respond to the quietest level, which is comfortable for them, why do we want to stick to our threshold so badly? Well, current hearing aid fitting algorithms use threshold measures as we've defined them. And so if we mess about with that, we are going to fit a hearing aid that is too loud, too soft, or various other problems. So I'll just go back to the patient instruction there. It also says, press the button as soon as you hear it and release it as soon as it stops. So this basically gives the tester 2 opportunities to be sure whether or not that person is actually responding. When it starts, and if they're holding it down until it stops, then they will release it. So for every presentation of the sound, you have 2 answers, if you like. The problem with that is that in reality, nobody does that. Patients do not do that. Patients will press the button when they hear the sound and immediately release it. They may start off by holding it down like we've asked them to, but that does not continue through the test. I cannot remember the last time a patient did that. It actually holds the button down until the sound stops and then releases it. This is a very long test with all the different frequencies and all the different intensities that we're presenting. It might be about 20 minutes long. We may be presenting maybe 50, 60, 70 different sounds. And after the first handful, they will just press the button as soon as they hear it. Also, one of the things that adults are very, very good at, and in fact, this starts very, very early in our auditory development. One of the things that humans are very, very good at is pattern detection. So if you start presenting the sounds, here's a sound, here's a sound, here's a sound, people will listen for that pattern and then start responding because they expect to hear the sound. So obviously we want to mitigate for that. So we have variable gaps in between presentations, and the length of the sound that we present is of variable differences to try and stop that pattern detection, although it does still happen. So on an audiogram, a lot of people here may well be very familiar with audiograms. However, it is worth, just in case anybody isn't, an audiogram is, generally speaking, sort of left to right is your increasing frequencies, and then top to bottom is quiet sounds at the top, loudest sounds at the bottom. And what we do is we plot the quietest sound at which somebody is hearing. So the better you're hearing very quiet sounds, and then right at the bottom, obviously, the sounds are louder. So what do we mean actually by good hearing? What are we actually aiming for? Where's our normative range? Well, there is quite a lot of very specific standards in terms of telling us what 0 dB HL, 0 dB hearing level actually is. And those levels have been derived from otologically normal individuals in a normal state of health. So this is as the definition within the standards, who is free from all signs and symptoms of ear disease and from obstructing wax, has no history of undue exposure to noise, exposure to potentially ototoxic substances, or familial hearing loss. It's worth mentioning that as these figures are updated, that's becoming harder and harder to do, because obviously noise exposure is on the increase worldwide, particularly in younger people, because the sound quality of our sound devices are so good now. People are exposing themselves to lots more noise. So actually gathering this group is going to be harder and harder as time goes on. However, currently, it's estimated that about 95% of young, normally hearing adults will have hearing threshold levels of less than 20 dB. So we actually set that range as to anything up to 20 dB HL we consider to be within the normal range for young adults. And the age range that we use to establish 0 dB HL is 18 to 25. So this is not across the age range of adults at all. It is a very, very specific group of young adults that we use to define 0 dB HL. And that's the reason. This plot is the reason. So a 60-year-old does not have the same hearing. Even someone without a clinically detectable hearing loss A 60-year-old does not have the same hearing levels as a 16-year-old. That's also true for frequency range as well as volume. So younger people in teenage years can hear much higher frequencies than older people. Okay, so we do tend to test, or should test, in a soundproof room, or in an occupational health setting. Very often you can get these little tiny booths, or you can use circumaural headphones to try and bring down background noise if that's not available to you. And we would typically we would always do otoscopy first. We want to make sure that the ears aren't blocked with wax, because that's going to obviously influence the results of the test. Remove hearing aids, glasses, headwear, or earrings. In reality, we don't always ask people to remove their earrings, but certainly it will be much more comfortable if people do. We do want to know if there's any noise exposure within the preceding 24 hours. We also want to know if there's any tinnitus. If somebody is reporting tinnitus, that's not going to stop us doing the test, but there may be certain frequencies which they're going to find difficult because the tinnitus is at the same frequency. And we'll ask if they think that they have a better ear, and we'll start there. So some of the sources of error immediately are people who are trigger happy. We do get that a lot. People love pressing buttons. So if you give somebody a button, very often people will love pressing it. They don't. Also, some people, once they've pressed the button, won't let go, and so you have to remind people to take their hands off the button in between presentations, or waiting so long that there's confusion, or getting bored and sleepy, because this is a very, very repetitive test. Pure tones are boring to listen to, and we're presenting lots of them. People do get bored, and their accuracy does go down over the space of maybe the 20 minutes that it takes. Okay, so if we just look at some of the equipment issues, supraaural headphones are currently the most commonly used. A lot of people, for instance, well, certainly within hospital sites where there are audiology departments, we don't tend to use circumaural headphones. People find them very bulky and heavy. And because we're using soundproof rooms usually or sound treated rooms in hospitals, it's not necessary. We do have inserts available to us, which I'll talk about in a second, but obviously we don't want to do that if there's much wax in there at all, because we could compress the wax. But if somebody's got collapsing ear canals, and that's not so much of an issue with adults, but certainly with younger people, the inserts will keep their ear canals open. But there are some other factors relating to transducers that are a concern. So if we use inserts as well, there's less risk of crossover. So whenever we present the sound being actually heard by the other ear, and we have some very specific figures as to at what level that's likely to happen. Also, there is a concern around the possible risk of accidentally reprogramming a shunt. Some shunts, which are basically a device which is implanted in somebody's head to help with hydrocephalus, these days, a lot of those shunts are programmable from outside of the head, and there's a risk that you could accidentally reprogram them. So the British Society of Audiology had a bit of a panic when this became a factor, and so we wrote some guidance to basically say that people should use inserts, not over the head headphones. And there are some shunts that are not accidentally reprogrammed. They're sort of resilient to this, but there are some where this could be a real issue. There's actually a working group on that document as well. So if you're interested in that work, do get in touch. As I say, we're going to be updating that document fairly soon. So we had just done some measurements of what the field was like around various transducers that we are using, and the risks to accidentally programming these shunts. And some of the difficulties, for instance, with headphones is the fact that, in terms of how we're using it within audiometry, we have no alternatives in terms of where we position it. Bone conductors, you do have some flexibility in terms of where it's positioned, and it doesn't have the same risks depending on which bone conductor you happen to be using. But I'll move on because I'm conscious of time, and there's some things that I would like to raise in terms of the methodology. So one of the biggest bones of contention with the current audiometry guidance is the risk of airborne sound. So when we do a bone conductor, so this is basically a piece that does exactly the same job as a headphone. It just sends the sound in through the skull, for anybody who's not familiar with them. And this basically bypasses the part of the hearing system where, for instance, you may have a conductive loss. So a loss which is, for instance, related to glue ear or earwax in the middle or outer ear. So it just, you can do the test again, just using your bone conductor, sending the sound directly to the cochlea. However, at higher levels, the bone conductor will produce this air-radiated sound that can then travel in through the air conduction route, which can create a false presentation on the audiogram. And so it has been suggested that what needs to happen is that you should wear an earplug to avoid that. However, we have to be slightly careful with earplugs because of the occlusion effect, where it will amplify low frequencies. So there is some documentation in terms of, or some studies looking at the extent of the occlusion effect in different age groups. So this is a particular problem. If there is, it might suggest that there is a conductive loss where there isn't one, and so you would have too many referrals to the ear, nose and throat department. It will affect your hearing aid fitting. So this is a real concern. And so it was recommended in the Pure Tone Audiometry guidance that actually 4 kilohertz bone conduction should not be done, because there was such a risk of this airborne sound being a problem that actually it was recommended that it shouldn't be done. So however, this has come under a lot of debate. There are a lot of clinical sites who ignore that part of the guidance and will do bone conduction at 4 kilohertz anyway. Now, as an organisation, if a section of the guidance is being regularly ignored, we have to challenge it. We have to look at the suitability then of the particular wording and saying, right, well, why are people rejecting this part of the guidance? What is it about clinical application that people are not doing? What is it that's unattractive about what we're suggesting that people do? This is sites who generally do follow guidance, but then they're picking out little bits which don't suit. So this is one of the areas where we're really looking at it again and saying, okay, well, if there are concerns about the accuracy of 4 kilohertz bone conduction, what should we put in place to mitigate for that risk that doesn't involve saying to people, you can't do that test at all? Okay, so in terms of our audiograms, this may be an indicator of a sensory neural loss. You've got circles on the right, crosses on the left, and generally speaking, these are color coded as well. So red for right, blue for left. The little triangles are bone conduction. So whenever the bone conduction thresholds are the same as the air conduction thresholds, you can be confident that a hearing loss is sensory neural. Then if there's a gap between the two, so if somebody's hearing better through the bone conduction than with the air conduction, it would suggest that there is some conductive element to that hearing loss. The most common audiogram that we typically see in clinical settings is presbycusis. So this is the hearing loss associated with old age, and you tend to lose your high frequencies first. So you'll hear people saying things like, oh, well, people are mumbling. I mean, they might be, but what's actually happening is that people are losing those high frequencies. And so it sounds, what they're picking up is the vowels, and they're missing out on the sh type sounds. Noise-induced hearing loss, also we can detect indicators of this in somebody's audiogram by a dip at 2 kilohertz. Then you have something called the Carhart notch. So sometimes you will get, with some conductive conditions, it will actually affect your bone conduction threshold by the way that the anatomy of the ear works. So sometimes you'll get this little sensory neural dip at 2 kilohertz, which corresponds with also an air conduction dip as well. So that will give us information about potential conductive loss. But as I say, for speed, I'll move on, but I can come back to this if that will be useful. And there are major diagnostic limitations with pure tone audiometry. So, for instance, auditory neuropathies are not detected by pure tone audiometry. Auditory neuropathies are basically where the signal is not traveling up in a coherent form up the auditory nerve. Also, auditory processing disorders, again, so far up the auditory pathway that it will not necessarily be apparent on a pure tone audiogram, and synaptopathies as well. So there are certain hearing loss. My point is there are certain hearing losses that will not be identified on an audiogram. Presbycusis, pseudohyperacusis, non-organic hearing losses. This is where somebody is presenting with a fictional hearing loss, somebody who has come along and is saying that they have a hearing loss, and it's not genuine, it's not biological. And there are red flags that you can sometimes identify on the audiogram, such as non-organic hearing losses tend to be completely flat, when most pathological audiograms tend to be of a different shape, tend to have different responses at different frequencies because of the anatomy of the ear. Whereas if people are creating a hearing loss out of thin air, it tends to be flat. They will only respond to the first levels that you present. And also, it's worth mentioning about non-organic hearing losses is that the vast majority of non-organic hearing losses are exaggerated hearing losses. They are not completely fictional. They are exaggerated hearing losses. Okay, so of course we should never take the pure tone audiogram in complete isolation. You look at it alongside all of the other information that you have. So in terms of test-retest reliability, most people will throw around the term 5 dB for test-retest reliability at any one specific point in your audiogram. So if you test on a Tuesday and you get 30 dB, then you test again on a Wednesday and it's 35 dB, that's not clinically significant. I'm not going to do anything about that, or very unlikely to do anything about that. However, what's really interesting is the fact that at higher frequencies, the test-retest reliability is much greater, the reasons for which are not clear. It may be related to the fact that when people's headphones are on and the placement isn't entirely accurate, it's more affected by that. And so we simply, as a profession, need to be more careful about placement on the ear. That could be it. But it is variable, and we're not entirely sure for the reasons for that. Pure tones is not what people listen to day to day. What they're interested in is how well they can hear speech, music, environmental sounds, and therefore pure tones is something that it's very difficult for people to get excited about. And some difficulties with concentration and sticking to task. Also, that person has to have the ability to wait and then act in accordance to what you've asked them to do, which not everybody has. Okay. So each individual would need good working memory, good inhibitory control, so they need to be focused on the task rather than thinking about other things, ability to understand the instruction, concentrate, and also the intolerance of uncertainty. Some people find audiometry very frustrating because we spend a lot of time presenting sounds which are right on the cusp of their audibility. Sometimes they'll hear it, sometimes they won't, and people find that irritating. Some people really find that uncomfortable and will become exasperated because these sounds are so quiet. So there is a risk that you could overestimate the hearing loss or underestimate. So sometimes you'll underestimate the hearing loss because people are pressing the buttons too frequently because they want to do what they're told to the point of it being inaccurate. So, but we can break it up obviously into multiple sessions, and there is guidance in terms of applying this to individuals with different cognitive needs. Also, there are some technical limitations in terms of, I've been saying we go down in 10 dB steps and up in 5 dB steps. There are obviously rounding errors. So in terms of just noticeable difference, the human ear can, in laboratory conditions, hear a difference of between 1 and 2 decibels. And we're in a clinical setting, we don't test to that level of detail, we test to 5 dB. So we're already inaccurate because we're using these 5 dB steps. And for some individuals who struggle with their audiogram, we may use even bigger step sizes than that. Transducer placement is obviously a bone of contention. In terms of how deep we put insert earphones, that will hugely affect the amplitude of the sound and can have a difference of up to 20 dB in terms of how deep we put the insert into somebody's ear. So somebody's ear canal is just shy of 3 centimeters long, and there's a lot of variation there in terms of how deep you're going to put the insert and therefore the impact on the threshold. Also, placing your bone conductor on the skull. Generally speaking, we assume a transcranial transmission of 0, so it doesn't matter where you put it. But in reality, some people do not have typical skulls, and therefore the sound will not necessarily be the same depending on where you put it. Okay. So in terms of areas of future depth, there used to be a test called Becochet audiometry, and in fact it does still exist in some of your automated kit, where basically instead of presenting the sounds as distinct, isolated moments of sound, you actually hold your button down until the sound disappears. So it's getting quieter and increasing in frequency, and then you release as soon as it disappears, but the sound is continuous, and then you're constantly pressing the button up and down when it appears and reappears. So you get this sawtooth pattern on your audiogram. And as I say, it's still available in some of your automated kits, but you won't see it in a clinical setting. And interestingly, there was a really interesting study which actually compared our current method with Becochet and concerningly found that Becochet gave better thresholds and had less test retest and had better test retest reliability than our current method. It makes you wonder then why we are continuing with our current method. Of course, that was a single study, and I think that is well worth revisiting because these other forms of testing are available and we choose not to use them. And our current guidance does not use Becochet audiometry. Interestingly as well, the automated audiograms are used very often, for instance, in occupational health settings, so screening in very noisy environments. And whenever studies have been done there with manual audiometry, they have produced reliable results that are comparable to your conventional results. Also, children really enjoy the automated tests because you can very often incorporate them with cartoons where a child is basically sort of pressing the button when the sound appears, and they enjoy that sort of visual imagery that can come with that. However, it's not without its difficulties, so that's not necessarily the solution, particularly with some groups who need greater engagement with a person, with a tester. This is just going back to what we were saying about step size. One of the areas that we're looking at as well is, do we want to stick with our 5 dB steps? Is there a justification now that we have the precision that we have whenever it comes to hearing aid fittings? Should we actually move to 2 dB steps? Now, that may seem like a point of no debate. Why not do 2 dB steps? This would be great. Problem with that being that this would make it considerably longer. It's already too long as a test, and people are going to get bored. And also, you're going to spend much more time around threshold, so people are going to get exasperated and irritated, and they're going to stop. So yes, you could potentially get more accuracy, but at what cost? Also the instructions as well. So I'm going to test, these are the full instructions, but in reality, people listen to one thing there. That can be reduced to press the button when you hear a sound. That can be reduced to one thing. If you give people this full set of instructions, then generally speaking, people will tune out, and then you will end up repeating it, but just with that critical information. Press the button when you hear the sound. Direction of change as well. So on one of those slides there was the mention of, where was it? Yes, the Houston-Westlake technique. This is an ascending technique. So instead of presenting a sound to say to somebody, this is what you're listening for, now we're going to go quieter. The Houston-Westlake technique did the opposite. It started below threshold, where you know it would be below threshold, and then you would increase it until somebody responds. So this is interesting because for non-organic hearing loss, so for fictional hearing losses, this is a much, much more accurate way of doing things. Because whenever somebody is presenting with a completely fictional hearing loss, if you present at 60, 60 is the only response you're going to get. So, well, for some. Obviously, sometimes they present slightly differently, but very frequently, this is what you'll get. They will respond to the first sound and nothing else. However, if you start below, then it can improve their threshold quite dramatically. If it's not in the case of somebody who's manufacturing a hearing loss, the difference actually between ascending and descending is less than our step size. It's only 4 dB. So there's a good argument for saying, let's just rethink this. If there's a group for whom this is more accurate, if we do ascending, why don't we just do ascending for everyone? Masking is arguably the biggest, and this is just the last point that I want to make before we have a discussion. Masking is the biggest point of debate at the moment, because this is the part which takes the longest. So if you have a difference between your two ears, there is if you have a big difference between your two ears, there is a strong possibility that one ear will, the better ear, will be responding to sounds that you're presenting to the worse ear. And in fact, you will underestimate the hearing loss in the worst ear. Because say, for instance, your threshold on your better ear is 0, and you are presenting sounds at 70 dB in the worse ear, and the worse ear still can't hear it because perhaps it's a dead ear. But actually at 70 dB, that could happily be heard by the better ear, even with headphones in place. If you're presenting 70 on the worse ear, this ear can definitely hear it. So what you have to do is present like a shh, generally speaking, a white noise, but there are devices where it'll be a narrowband noise focused on the frequency that you're testing, coming into the better ear, just to give that ear something to do, because then that ear will not pick up the tones that you're presenting to the worst ear. And currently, that part of the test is very time consuming, because what we do is when we introduce the masking, the threshold obviously will go up because the worse ear or the better ear can no longer help with this. So you're going to have to go up and up and up until you start to get a threshold in the worst ear. And so you keep going up until you get a plateau where the better ear is no longer being engaged at all. And so you're then going to get that flat line. It's also very difficult for patients as well to listen to two sounds. You're presenting a white noise, you're presenting pure tones, and you're asking them, I want you to ignore one sound and listen for another. There's quite a lot of patients who find that really tricky, really tricky to focus on one sound rather than another. So the debate is, should we actually spend time re-establishing threshold? Is that too difficult? Maybe we should just present a loud masking noise in the better ear and just do one measurement on the worse ear. So that you, instead of finding this plateau, you're actually just presenting a single level. Also, there's debate around the calibration levels of the masking noise that we present, which there isn't time to discuss today. But if you want more information about that, that working group looking at pure tone audiometry has developed this really nice document exploring the issues with this. And the bandwidth of the masking noise, that will depend on the device that you're using. So do get in touch if there's anything that I've touched on today that you would like more information on, or if you'd like to come along to Manchester and have a go with audiometry and we can explore it a little bit more, would be more than happy to support with that.
Thank you very much. Thank you very much, Siobhan. Can you hear me?
Yes, I can, yes.
Good. So any questions online or in the room for Siobhan? It would be really helpful to know from the lab's perspective any thoughts that you have on the use of pure tone audiometry for screening for human participant testing.
Absolutely.
So we do similar sort of tests, but with and without the hearing protection, so be that earplugs, ear defenders, helmets, whatever. So there's screening, but I don't think it's particularly harsh screening. You need to have fairly normal hearing. Mine is not good enough, for example. So, I guess one question I did have is, you get people who can push the button when the sound stops rather than letting go.
Yes,
I think last time I did it, last time I had an audiometry measurement. I didn't notice the sound until it went away. Is that
Yes.
Yeah.
Yeah, that's a really interesting phenomenon. Absolutely a really interesting phenomenon because, and this fits in with one of these phenomenons where, and we think it's related to survival, is basically the ear is really, really good at listening for change. And we're very, very good at filtering out sound that we don't need so that we can focus on sound that we do need. So for instance, the sound of a fridge or the sound of a ticking clock and so on, we're actually quite good at ignoring that. And one very slightly worrying study found that actually people are better at filtering out their spouses than anybody else in terms of ignoring background speech. They're better at doing it with their spouses. Now, to be fair, this is possibly because they're more accustomed to their spouse, and therefore the ear will recognize the detail of that speech more than anybody else. But yes, you're absolutely right in terms of the ability to filter out and ignore sounds that we don't need. And so we do sometimes find this, and we also find some patients will actually, it's not so much that they haven't realized that it's there until it stops. Some people will wait until it stops because they think that that's what you want them to do. So it's almost like, right, well, you've done it now and now I'll respond kind of thing. But even patients who start doing that at the start of the test, waiting until it stops and then presenting, tend to, as the test moves on for speed, I think that they will just then start responding whenever the sound is first presented. But yeah, it's a really interesting phenomenon that, and in terms of using it as a screen, yes, absolutely. There's some really quick ones. So I've been sitting here talking about, oh well, it's so long, it's so boring, it's but in fact that's only for a full clinic sort of clinical based diagnostic audiogram that we're going to use to, for instance, influence referrals to different parts of the hospital, or to fit amplification, or refer for cochlear implants, or something like this. So the major test may take 20 minutes, but screening audiometry can be very fast.
Yeah, that's what we do.
Thank you so much, Siobhan. I think the next question is from Nathan online. Nathan, would you like to speak?
Yeah, sure. Thank you, Siobhan. That was really, really interesting. It was, it was just not necessarily a question as such, or just a thought. You mentioned about the Beckershey
Yes.
technique, and it kind of no longer being used. I've always thought that kind of audiometry tests are a little bit coarse, but I understand the requirement to kind of balance like time with that, with accuracy. So I just wondered if you knew the reason why the kind of Beckershey technique was moved away from, and what's the kind of duration of those tests?
Yeah, absolutely. And I don't think it's clear, because so this is one of the things that the working group has been looking into, and I think it may be availability of equipment. So as this our current technique sort of came in the 1960s, it was adopted by so many devices, and then it becomes sort of widely available, and people go, oh right, is that what we're doing now? And there's a few devices within the occupational health sector which continue to use Beckershey, and it is really, really interesting the fact that it's not being used. And I'm not sure that there was ever a consensus where people went, do you know what, we're not doing Beckershey anymore, because the evidence doesn't suggest that it was ever a bad test to do, or that it was problematic in any particular way. Most of the comparisons show that it's certainly just as good in terms of accuracy and retest reliability. And as I said, that one that I showed was even better. So I think there wasn't a consensus, and the BSA only started in 1967, and that was the point at which guidance came in, and the guidance was using this new technique. So whether it was actually our fault because we developed this guidance and people sort of went with that because that was the trendy method at the time, and then we've ended up sticking to it, perhaps.
Fair enough. That's very interesting. But yeah, to my mind, it seems to make a lot of sense, the Beckershey. So yeah, no, very interesting. Thank you.
Thanks.
Thank you, Nathan. We have a question. Sorry, just a moment. We have a question from Addy, and then perhaps we'll have a final one from the room. So Addy's test was about how to do pure tone audiometry testing for someone with tinnitus, and she asks about the masking procedure in particular. But could you comment first on how you would approach obtaining the thresholds for someone who has tinnitus, who describes having tinnitus?
Yeah, absolutely. So this is a great concern to people with tinnitus. They are worried themselves that actually whenever that they won't be able to do the test, and so we do inquire about tinnitus at the start. There is tests called pitch matching and loudness matching, where sometimes what an audiologist can do is identify what frequency their tinnitus is being heard at, and so you can basically say, right, well, that frequency is going to be inaccurate, and I'm going to get intermediate frequencies on either side and extrapolate. So you could either do that, you could either extrapolate and just ignore what's happening at that particular frequency, if your tinnitus happens to be falling on one of the test frequencies. Or sometimes somebody will actually comment when they're doing the audiometry, that's my tinnitus frequency. I don't know what I'm listening for. I don't know what I'm listening to. In which case, we can take that into account and basically say, right, well, we're going to ignore that and move on. Another alternative is to use a warble tone. So yes, these are pure tones and everything, but warble tones is something that warble tones are quite useful for also individuals with cognitive needs who may find pure tones too or not stimulating enough. Warble tones are more interesting to listen to. So sometimes we'll use a warble tone to help somebody differentiate it from their tinnitus. If their tinnitus is a kind of a whistle, but tinnitus, of course, can present in many different ways. So tinnitus can be like a rushing or something like that, or it can be like a whistle. And if it's a whistle, then warble tones can be quite helpful, because then you can say to somebody, listen for this warble, not the pure tone. And then just do that for that particular frequency. And pretty much every clinical audiometer should have that as an available to them. You can also get audiometers with pulse tones as well. I don't think pulse tones are as helpful though, because they're going on and off, but the sound whenever you're presenting it is on and then sometimes off. So I think that's harder to differentiate really. And yeah, so around masking, if it's a rushing noise, that is very, very challenging indeed, and that can be a problem, and that's more difficult to come up with a solution for.
Thank you, Siobhan. And a quick question from the room.
So I was thinking that basically what you do with this test, it's like using an equalizer, selecting a single frequency and dropping everything else off. And you go from 250 to 8K. But actually, we don't hear like that, do we? We hear complex frequencies. And it reminds me basically when audio engineers, they just single out a single track in a music composition, and they sort it out, and then they add the others, and the track goes away. So I don't know if it's possible, but would it be possible to find a test where all the frequencies they are played at the same time, and then you modulate a single one to detect when you can hear it above the others, because then you have a bit more a clear idea of what's happening to your ears when you actually perceive real sounds. So what you hear is a single sign coming into your ear.
Yes,
but it's not reality, is it? It's like in a test with light where you only select a single band of a color at time.
Yeah, absolutely. I think that's definitely worth exploring, and certainly. There's in terms of, for instance, some of the screening tests that are used, very much lean into the fact that, well, actually, in reality, what people are listening to is something else entirely. And therefore, they are only going to instigate any kind of rehabilitation if they notice themselves an issue with real life sounds. So the World Health Organization screening device, for instance, which you can download, or you can use their app, or you can go into the website, and they use a digits and noise test, which is very, very popular for screening now, but not least because you don't need a silent room to do it in, and basically it presents quite a lot of background noise, very realistic background noise, the sorts of background noise that you will come across, and then you have to listen to 3 digits at a time at different levels. And it's actually the signal to noise ratio that's being measured, and that's the point. Because and one of the reasons that is really, really effective is the fact that whenever we have a hearing loss, we don't just lose volume, we lose the ability to filter. So this signal to noise ratio is what's used to indicate to somebody that actually they need to go and see an audiologist.
Brilliant. Well, I think that's the end of our time today. Thank you very much, Siobhan, and thank you for your generous offer to our students and others here. We're very grateful.
My pleasure.
Thank you again very
My
much.
pleasure. All the very best. Bye.
Thank you. Bye-bye.